Good morning and welcome to Georgia Heart Grand Rounds. Thank you all for joining us today. The planners and speaker have disclosed no relevant financial relationships with commercial interests. We have a new process for checking in your attendance. Please make sure you scan the QR code at the registration desk to sign in. If you're virtual, the link is in the chat. And now it is my pleasure to invite Dr. Samity to introduce our very special guest, Dr. Jagat Narula.
Well, good morning, everyone. It's a distinguished honor to present this morning's cardiovascular Grand Round speakers. I know that there are quite a few people online as well, and we'll have more coming in shortly. Professor Narula is a world-renowned physician scientist and leader in academic medicine. He joined the UTHealth Houston, University of Texas Health Houston, as Executive Vice President and Chief Academic Officer in January of 2023. Dr. Narula's considerable and far-reaching experience includes leading cardiology and cardiovascular imaging programs, as well as global health initiatives, conducting translational research that advances clinical care and emphasizes heart disease prevention. Dr. Narula is currently President-elect of the World Heart Federation and has served as Editor-in-Chief or Executive Editor for several prominent scientific journals, including the founding Editor-in-Chief of the Journal of the American College of Cardiology, Cardiovascular Imaging. He has received numerous professional accolades, including the Distinguished Scientist Award, a Gifted Educator Award, as you'll hear this morning, and an International Service Award from the American College of Cardiology, and has been recognized as one of the masters of the College of Cardiology. He currently holds the K. Lance Gould Distinguished University Chair in Coronary Pathophysiology at the McGovern Medical School at UTHealth Houston. As you all know, Dr. Lance Gould was really arguably the father of coronary physiology, and has done much of the seminal work that the whole field has been based on. Prior to becoming one of the many faces of UTHealth Houston, Dr. Narula was the Philip H. and Harriet L. Goodhart Chair of Cardiology and Chief of the Division of Cardiology at Mount Sinai, Morningside. He served as Professor of Medicine, Diagnostic, Molecular, and Interventional Radiology, Artificial Intelligence, and Human Health, Population Health Science and Policy, and a Health System Design and Global Health at the Icahn School of Medicine at Mount Sinai. In addition, Dr. Narula was Associate Dean for Global Health and Director of Cardiovascular Imaging at Mount Sinai Health System. Previously, Dr. Narula was an academic and clinical leader at All India Institute of Medical Sciences in Delhi, Hahnemann University School of Medicine in Philadelphia, and the University of California at Irvine. He earned his medical degree from the SMS Medical College in Jaipur, where he completed his internal medicine residency and went on to do fellowship in cardiology and earned his PhD in molecular immunology at the famous All India Institute of Medical Sciences. He then concluded fellowships in cardiology, cardiovascular imaging, and heart failure and transplantation at Massachusetts General Hospital and Harvard Medical School. Well, ladies and gentlemen, there's a lot more I can tell you about Dr. Narula, but if I can just add a personal anecdote, that I had the privilege of meeting Dr. Narula when I was a cardiology fellow, like many of you here this morning, at Yale University, where he came and gave cardiovascular grand rounds after a seminal paper on apoptosis in the New England Journal of Medicine that really kind of helped shape our field and the importance of that aspect of vascular and cellular injury. Since then, he literally has led the field in cardiovascular imaging, vascular biology, plaque vulnerability. And so today this is a distinguishing honor for us that he's joined us. And the title of his talk is, Can We Eliminate Coronary Disease in Our Lifetime? Dr. Narula, please come join us.
Thank you, Dr. Samedi. It's indeed a pleasure to be here, and many thanks for this long-winded introduction. I don't think I deserve more, but it's truly a pleasure, and I remember those days when I met Dr. Samedi in Yale, and that was the time that our mentor, common mentor, Dr. Barry Zaret, who just passed away about a year and a half ago. So he brought him as the young investigator in one of those nuclear cardiology meetings in Winter Green, where we had a time to get together and talk to each other. So, and we have continued to kind of admire each other's work. And more importantly, today I will show you one of the slides. It is inserted right somewhere in the middle of my presentation, which actually has completely changed my thinking and how exactly I changed the way I started to look at the vulnerable plaque. And last night we were discussing whether there would be possibilities that after a friendship of almost 30 years, 25 years, he doesn't look that old, by the way, but there would be an opportunity that we would be able to work together. So can we eliminate coronary disease in our lifetime? And I'll try and focus on the chronic stable coronary disease today, specifically towards the revascularization role of CT angiography, focus on plaque, patient or population, and how to live to 100 without a heart attack. And that is the phrase that Dr. Braunwald introduced in one of his opinion pieces in European Heart Journal, which I really caught on. And it is really, that would probably be my last slide when I complete my presentation. So as Suzanne just said, that there is no conflict of interest here. So as I always show this box, of course, it's all empty, so there is no conflict of interest here. So I'll try to deal with the most contentious topic of the importance of anatomic, physiologic, or pathologic basis of coronary disease, and whether our focus should remain on the coronary lesion or plaque, patient, or on the or should we tweak the entire community. So let me start with this dogma that has consumed the cardiologists for decades after decades, and the dogma is that everything is all stenosis, right? And as you can see, that coronary artery disease is bad. Why is it bad? Because it causes heart events, it results in death and myocardial infarction. And we have always believed that there is some progressive atheroma that leads to significant stenosis. Stenosis leads to reduced flow, so there is ischemia, and that causes events. So obviously coronary artery disease is bad, and the stenosis is bad. And once we have set that dogma, we basically can easily find the solution to that also, and that is that you have to find the coronary stenosis, because the problem was coronary stenosis, and that causes ischemia. You will find ischemia because it causes events. So you just simply have to treat stenosis, which will reduce ischemia, and you would hope that fixing the stenosis and reducing ischemia will automatically mean less myocardial infarction and death. Now, has it turned out to be true? So where did this dogma start? It wasn't a dogma when it started. And this was the large randomized prospective trials, which actually set the field of cardiology ahead of other fields of medicine. And that was the paper in Lancet, one of the earliest studies, the European Coronary Artery Surgery Study Group, followed by the CAS, which was the study carried out here, and also followed by the VA administration study, that demonstrated that coronary artery bypass grafting did much better than the then optimal medical therapy, whatever was available to us in those days back in 1980s and 1990s. And they demonstrated that if the patients were treated with surgery, they did much better. in a long-term follow-up as compared to the optimal medical therapy of that time. And what was the optimal medical therapy of that time? Some people had beta blockers, some people had few of aspirin, there were no statins, there were no ACE inhibitors, nothing of that sort. But surgery did better, and all the people who had more than 70% stenosis, they were subjected to the coronary bypass surgery. Not only that, it prolonged the survival, it also improved the angina, and the freedom from angina, as you will see in the surgery group, was much better as compared to optimally medically treated patients. Not only that, their exercise tolerance also improved significantly. And where did this 70% come from? This 70% came from, as Dr. Samedi just talked about, Dr. Lance Gould, whom I consider my mentor, and I'm very proud to be bearing his name for my endowed chair. So Dr. Gould had done the early experiments back in early 1980s in the canine experiments, where they demonstrated that the 70% lesion was the one where exactly the ischemia started. Now, the issue is that here there is a single artery, which is a normal artery, which you occlude and try and demonstrate that the flow starts to reduce at 70%, and that became a gold standard for us. Now, there are two important things here. One, was the pathology the same at that time? And two, whether we had enough of the medical therapy at that point in time. If you look at some of the pathology studies from that time, and this is one of the best pathologists of our time, Dr. Michael Davies from United Kingdom, demonstrated that the plaques, which had significantly large necrotic core and thin inflamed fibrous caps, the experiments which were proven by Dr. Renu Virmani later on in mid-19s in the United States, we demonstrated that there is a significantly different plaque pathology which we used to see in those days, and that was in the absence of statins. Do we have similar lesions now, and would we have similar outcomes when we bypass these lesions? It remains to be seen. And then, as I discussed, whether we had enough of medical therapy available to us. So in early 2000, it requires significantly a courageous attempt on the part of Dr. Borden that he restarted the COURAGE trial. And if you remember from the COURAGE trial, the optimal medical therapy of this century, compared with the percutaneous coronary intervention in the patient with the chronic stable coronary artery disease, also it demonstrated that there was essentially no difference in the long-term outcomes up to 5 years. There was no difference whether you treated the patients medically or surgically, and that was the time that the numbers of the PCI reduced significantly, not only in the United States, but across the world. Now, when this was happening, simultaneously, there was a FAME group of studies which started to demonstrate that it is not the anatomy, but it is the physiology which is more important, and we need to demonstrate to have the best results. We need to demonstrate that the lesion is physiologically or functionally important. And they demonstrated that if we did the FFR at the time of coronary angiography, and we based our judgment of doing the undertaking the revascularization based on the functional ischemia, we performed better. And obviously, in the subsequent attempt, which was the FAME2 study, there the people with the abnormal FFR were subjected to the optimal medical therapy and compared with the in a randomized fashion to the percutaneous coronary intervention and optimal medical therapy, demonstrated that the intervention did much better, and that became a gold standard for us, that as we treat our patients, we must demonstrate the importance of functional ischemia in those cases. So, how do you reconcile the COURAGE trial and the FAME2 trial? And the best is if you would read the editorial on the FAME2 trial by Dr. Borden himself, where he asked the question, what is more enduring, courage or fame? And he demonstrated, and not only that he analyzed the FAME data, he also pulled out his own data and reanalyzed some part of it and demonstrated the similarity between the two trials. You will see that as we look at the 5 years period, now this FAME2 study, if you remember, was stopped at 7 months' time because they had met the primary endpoint. But essentially, the difference in the optimal medical therapy arm and the PCI arm was essentially because of the need for revascularization and not because the number of the patients who died because of the cardiac causes or who had myocardial infarction related to the target vessel was different in the two arms. And as you can see here, that this result or a difference of the medical therapy and PCI is essentially replicated in the urgent revascularization. While you go to the right panel here, you will see that there is essentially no difference in the death, and the myocardial infarction related to the target vessel is slightly greater but it is statistically insignificant. Now, if you reanalyze the courage data also, there is no difference in the death or myocardial infarction. So the difference in the two studies was essentially based on the y-axis. That is, that the subjects who had the death or myocardial infarction was the primary endpoint here. However, in the FAME2 study, they had added yet another parameter here, which was the need for urgent revascularization. So if you look at the need for urgent revascularization, quite similar to what we had seen in FAME2, Courage also had that, but essentially there was no penalty for postponing it to the time when you needed the revascularization, essentially saving quite a few revascularizations in that process, which even turns out to be true, as I will discuss in some of the slides at the end. However, when this debate was going on, we were hoping that the ischemia study, which was a much larger study, which was expected to be much larger study, and was looking at essentially the people who had the gray zone and not clearly the black and white, essentially like left main or very severe triple vessel disease, those are the people you will exclude, or the normal coronary arteries or mild disease you will exclude, and you will only include the patients who are truly in the gray zone. We thought we will really get an answer from the ischemia study. But what did we find after the ischemia study? Same, about 5,000 patients, 5 years follow-up. You'll see that it was absolutely a same result as that of Courage, that there was essentially no difference in the outcomes whether the patients were treated with the conservative therapy or they were treated with the invasive therapy, whether that was coronary bypass surgery or percutaneous coronary intervention. However, in their subsequent study, which or in their subsequent presentation, which was followed after a year in Circulation, where they looked at the spontaneous myocardial infarction, they demonstrated that the invasive arm was able to prevent the acute myocardial infarction or spontaneous myocardial infarction in this particular case by at least 50%. So the spontaneous myocardial infarction rate in the conservative arm was about 6%, and in the invasive arm was about 3%, with the absolute risk reduction of 3% and relative risk reduction of 52%. So the question that was asked is whether did ischemia study demonstrate failure of revascularization to reduce myocardial infarction? Or is it failure of ischemia testing to guide revascularization? So essentially, the onus is on us to find out who will live without events and who will die of preventable events and when. So we need to find the Waldos here. Okay. So how do we do that? And that was the time when I chanced upon and was lucky that I was the associate, I associate edited the paper which Dr. Samedi submitted to Jack, and learned a lot. Was completely consumed in his revisions that he sent, and every single time asking more from him. And he satisfied the entire editorial board and brought a new direction to it. Now, what is that he tells by that particular paper here. So if you look at the FAME2 study, at the end of 5 years, essentially, you needed an extended follow-up. So initial study was 7 months or 1 year presentation that was there in the European Society of Cardiology. And then you will look at the 5-year follow-up study where you will say that the PCI is superior to optimal medical therapy for FFR positive lesions. However, at the end of 5 years, you will see that half the people do have events, whether it is death, myocardial infarction, or the need for revascularization. However, in 50%, essentially 50% of cases, to be very exact, it was 49%. In 49% of cases, you do not have myocardial infarction. Patients do not die. They do not require revascularization, and their freedom from angina is the same. Can you find those people? The people who are likely to do better versus those who are not likely to do well. And it's essentially 50%. It's not a small number, right? So he looked at, with Dr. Brian DeBryan, obviously looked at the FAME2 data only in a optimal medically treated group, which was a very elegant study design. Now you have a follow-up available for 5 years in these patients. You've got the patients who are optimally treated. These are the people who have got significant stenosis. These are the people who have got functionally proven ischemia. And he looks at their shear stress and demonstrate that the people who had abnormal shear stress, they did much worse as compared to the people who had normal shear stress. That would there be a possibility that I'll be able to identify those people who are likely to do better without, or who are likely to do equally well without having intervention at that time, and how did it change the way we were trying to practice? And that was that what we thought was that everybody who has got a 70% stenosis, all of them should go for surgery. That is what we used to think, or go for revascularization. Then you will say, what do we think now? We currently think that we have to demonstrate the functional ischemia, as shown by the FAME2 study. But that takes away about a 33% of people away who, in spite of having 70% stenosis, do not require intervention. Now, if you look at Samadi's data here, you would say that you can still take about 50% people further away, taking away those who are FFR positive, but they have normal shear stress. And can I really extrapolate it to say that these people have different kind of plaques so as to give the abnormal shear stress in the coronary pathophysiology? Would I be able to take that bite further away? And if these 50% people are taken away, I will be left only with about 33% of the people who would truly require the revascularization in chronic stable coronary artery syndromes. So, if we are talking of the abnormal shear stress or the high-risk plaques here, who are likely to have an event, because the event is occurring not because of stenosis, the event is occurring because of the abnormal plaque, which is likely to rupture and result in an acute coronary event. So you know that these plaques, as I showed earlier also in Dr. Davies' studies, that they have huge necrotic cores. Here you will see that it is full of cholesterol crystals here. It has got a very thin fibrous cap, and we know that when the fibrous cap becomes less than 85 micron, it becomes a vulnerable plaque, and then it ruptures, and this plaque is normally significantly inflamed. Now, if you will look at the middle panel here, you'll see that this plaque has all those features which is there in the left panel, but the fibrous cap is still intact, and these are the plaques which we call as high-risk plaque, or plaques that are vulnerable to rupture. Now, on the right-hand panel, you will see that these are also vulnerable plaques, huge necrotic cores, thin fibrous caps. But the difference in these three plaques is that this particular plaque on the right upper corner, it has thin cap, it has large necrotic core, but the lumen is not affected at all. In the middle panel, you will see that the lumen is modestly affected, and in the right lower panel, you will see that the lumen is significantly occluded here, or critically stenotic artery. This is the one which can give rise to chest pain. These two are not going to give rise to chest pain, but all three are equally amenable to plaque rupture. And the reason that you are able to develop such a huge plaque without occluding the lumen is because there is initially an expansive remodeling or outward remodeling or positive remodeling of arteries, as you call it, by the intravascular ultrasound studies of Plaque, and essentially that can continue to happen until the total plaque area consume at least 40% of the total vascular area. So approximately 40 to 60% plaque area, until that is covered by the necrotic core or the fatty deposition, the artery may not start to show the coronary or the luminal stenosis. Now, if we try and identify such plaques by non-invasive imaging, excuse me. So this is something that we started to look at in 2003 when I was lucky to receive my first CT scanner from Toshiba as a gift. And that was, I was lucky because I was in UC Irvine and Toshiba was right in our backyard. And these people came, and as I was working in the vulnerable plaque in pathology with Dr. Birwani, and also was lucky that I have been heavily supported by the pathologists all my life. So Dr. Birmani, then Dr. Luisa Arbustini, and finally my wife, who is a cardiac pathologist. I have always been surrounded more by pathology than by the living patients here. So essentially, as I was looking at that, and so here I get the gift of a 64 slicer. That was the first scanner that came to the country. And we started looking at the people. Expectation was that we will look at about 3,000 subjects and we will be able to redefine the vulnerable plaque as the non-invasively identified entity. So we started to compare the intravascular ultrasound with the CT angiography, looked at the vessel wall in the CT angiograms, and this is one of the early images from 16 slice that we had earlier started to do, but then later on moved on to the 64 slices. After comparison with the intravascular ultrasound, we found that the necrotic cores correlated with the 30 Hounsfield unit density or lower, and between 30 and 150 were the fibrous plaques, and beyond that is the lumen contrast, and even beyond that was the presence of calcification. But the important thing we found in the subjects who had had acute coronary syndromes and they had come with the lower intermediate risk to the emergency room, and we were able to look at their CT angiograms or take them to the CT angio suites before we took them to the cath lab. We found that there were two important features in the people who had presented with the acute coronary syndrome. So here is a patient, 57 years old, with the acute coronary event, had unstable angina pectoris, presented 24 hours after the onset of chest pain. He was fully relieved when he comes to the emergency room. But as you would see in the CT angiogram, there were two important features. And one was that there is a positive remodeling here, as you can see by the yellow arrows, and then the presence of the necrotic core or the Hounsfield unit densities of less than 30 Hounsfield units here. And we called these plaques as soft plaques or vulnerable plaques or high-risk plaques. However, when we were publishing the data, the JAC editors did not let us call the vulnerable plaques because it was not the prospective study, and we were presuming that these are the high-risk plaques, and they wanted me to call it with some non-specific name. I didn't think that there could be anything more non-specific than just calling them one feature and second feature. So we started calling them as two feature positive plaques. And it has now become a lingo that you call them as two feature positive plaque, one feature. Or if you find more features, you call them as three feature, four feature, whatever you want to call them as, or two feature negative plaques. The two feature negative plaques are the stable plaques. Here you would see that the stenosis is significant, but there is no positive remodeling. There is only the fibrous plaque that you can see here. And there is essentially no necrotic core in this particular case. So this is two-feature negative plaque versus the two-feature positive plaque here. And when we look at the follow-up, so this is the 2-year follow-up, at least 2-year follow-up in 1,000 subjects, and you will see that the two-feature plaques had 22.5% likelihood of having an event every 2 years, suggesting that there was a 45 times higher likelihood of having an event if you had a two-feature negative plaque. So we thought that we have found an answer. We knew that we can identify the vulnerable plaques. We thought that we have conquered the field. But the life is not so easy. Even though we found that more the remodeling index, more the plaque volume, more the necrotic core volume, more the necrotic core to plaque volume, it was associated with the greater likelihood of having an event, and earlier was the event if these features were greater. Now, in spite of all that, when we look at 3,000 subjects and a 10-year follow-up, you will see that the outcome of the non-high-risk plaque is not as benign. So in 2 years, essentially you saw that there is no likelihood of having an event, less than 0.5% likelihood of having an event. However, when you look at about 2 years, about 10 years, there is approximately 2.5% likelihood of having an event. Why? Because some of these plaques turn into high-risk plaques over a period of time, and that would result in an event. On the other hand, the high-risk plaque does remain the high-risk plaque. So approximately 10-fold higher likelihood of having an event in the plaques if there was high-risk plaque compared to those which were non-high-risk plaques. Which are these people who really become amenable to the acute event? And they were the ones which demonstrated the evidence of plaque progression. And that is where we started to say that the most important predictive element of the vulnerable plaque is the plaque progression. Now, if you look at our study of 3,000 subjects, 500 were those where we had an availability of a second scan when it was done in about a year later, at an interval of about 1 year. For whatever reason the scan was done, those who demonstrated the plaque progression had even 35 times greater likelihood of having an event as compared to those who did not show plaque progression. As a matter of fact, if you have a high-risk plaque and there's no plaque progression, plaque is not going anywhere, compared to the one which shows a significant increase in the plaque progression, leading to an event that after 10 years, the number of the plaques which will result in an event was same for high-risk plaques versus non-high-risk plaques. Now, why do I say that? That at any given cross-section, today, 90% of the plaques are non-high-risk plaques. Only 10% of the plaques will be high-risk plaques. 10 years later, even if I have a 10 times higher likelihood of having an event with a high-risk plaque, the non-high-risk plaques, which are 1/10 in the number, 10 times more in the number, 1/10 of a likelihood of having an event, they will end up going to be the same. Essentially suggesting that doing one CT angiogram is not going to give me the answer. What is going to tell me is that yes, you have atherosclerosis, yes, you have a dangerous event, dangerous plaque, yes, I need to be way more aggressive. Obviously, it helps in a preventative regime much more significantly. Not only that, when the plaque progression starts to occur to a significant extent, we also found that the two most important features that contribute to the abnormal FFR were, one, the increased coronary stenosis, and the second was the presence of necrotic core or the extent of necrotic core regardless of the amount of the luminal stenosis. Now here, your shear stress is going to come very important in this particular case. So here you would see that it is the low attenuation plaque volume and the quantitative coronary stenosis, which are the two most important features that identify the FFR. Now, why would that happen? Why would there be a possibility that the FFR will become abnormal if there is no luminal stenosis? The reason is probably because the Glagow's hypothesis will come here again. You have got the maximum expansion of the external elastic lamina. It cannot go any further. Now, even if you give the vasodilators to them, whether it is nitroglycerin or adenosine, You will dilate the artery above, you will dilate the artery below, you will have a bottleneck, and that will cause the abnormal FFR in these cases. So, suggesting thereby that even the abnormal FFR will start to occur when you have got a significantly expanded or positively remodeled coronary artery, and the outcomes may be as bad in terms of FFR as there would be with a significant stenosis of the lumen. And it indeed demonstrated that, replicating what Habib Samadi has seen in his study of the subsequent study of the FAME2. Now, in this particular group of patients, we have 750 patients here, where we had the CT angiograms available to us before these patients were sent, and that was the physician's discretion. That patient was sent for coronary angiography, and based on coronary angiography, the physician decided to do the coronary intervention or not. Now, what we did was that we took those CT scans, we identified the FFR based on the CT scans, and we identified the presence of high-risk plaques, giving us a probability of creating a 2x2 table here. Now, this 2x2 table, which is FFR abnormal, FFR normal, high-risk plaque present or high-risk plaque not present. Very simple 2x2 table here. Now, what do we find? That if you have abnormal FFR and high-risk plaque, both present, then the revascularization did way superior to no revascularization. 10 times better outcomes if you have the revascularization in these cases. So, could this represent unsafely deferred group in coronary ischemia? Could this represent appropriately chosen group of FAME2 study? Or could this have been an alternative population or a better population for Prospect 2 study? Right? Now, let's go to the FFR, which is normal, but high-risk plaque is present. Now, this is the most contentious topic here. You just saw the PREVENT study, which was presented in ACC, and at the end, I would like to show you a few slides if you will have some time left. I didn't want to contaminate my presentation here by discussing something beyond what I wanted to say. So, this represents the past Prospect 2 population. Could this group be treated with aggressive lipid-lowering therapy? Why? Because the outcome in this particular case, revascularization did better. PREVENT also did the same. Prospect 2 also did the same. But they were never statistically significant outcomes. So why do I not treat them with simple lipid-lowering therapy? Right? So, do plaques imminently at danger of rupture need better identification? That is the crux here. Can I identify those people who are likely to have a rupture? And that is where the assessment of the high-risk plaque, sure, but more importantly, things like what you do might become handy. Right? Going to the third group here, FFR is abnormal, but there's no high-risk plaque. Does this group represent true courage or ischemia proposal? Could this population be safely deferred from FAME2 indication? Or could these be the ones who have normal shear stress of less than 4.71 PA? Right? Revascularization, 2.8% outcome. No revascularization, 2.7. Essentially, rock solid plaques. Nothing is going to happen to these plaques. Right? Why do I need to do the revascularization? They are likely to even have the same freedom from angina if you treat them optimally with the medical therapy. Coming to the fourth group, obviously, it's going to be a class 3 indication. Right? So, the Prospect 2 study did look at the significant plaque burden or presence of the significant near-infrared spectroscopy determined necrotic core or the total lipid core burden index, and demonstrated that the outcomes were somewhat, the major adverse cardiac events were somewhat better with the prophylactic PCI. However, it was statistically not significant, and they thought that this is probably because the numbers were not enough to demonstrate the importance, and that is where the PREVENT study took its origin, and they did 1,600 subjects to demonstrate the importance of treating preemptively those subjects who have normal FFR but presence of high-risk plaques. Now, what if I treat them with medical therapy? So here you would see that this is a subject. He's a CEO of one of the major firms who came to me. His father had died of acute myocardial infarction, so he was quite worried. He lived his life well. He's still 70 years old, has been doing extremely well. All parameters are normal. He was on statins. He was taking 10 milligrams of rosuvastatin. And as you can see here, that when we do the CT angiogram, he had a positive stress test. We did the CT angiogram and look at the FFR. There is a significant drop here at the mid LAD here, right? And if I look at the plaque morphology, you'll see that there's a huge necrotic core. Lumen is about 25 to 50% occlusive here. And then we started the patient on, we did discuss with him that he could go for an intervention because FFR is abnormal. But again, 50%, you could talk him into medical therapy also. 6 months later, as you would see, that the necrotic core has disappeared, the positive remodeling is gone, and essentially you will see that the FFR has returned to normal in this particular case. And that is what we have shown in our yellow 2, yellow 3 studies also, that when we reduce the necrotic cores, there is a significant improvement in the FFR in these cases. Now, if you look at various statin therapies, you will see that if you have to demonstrate the halting of the plaque progression, you need to bring the LDL level down to 70. If you need to regress the plaque, you have to go lower than 70. And these are the intravascular ultrasound studies coming from Dr. Steve Nissen's group, all of them put together. Now, if you go even further down, again, Steve Nissen's group, as well as where we have done the yellow 3 trial, and then the other studies coming from Steve Nichols, whether it is the Glagau or the study later on with the optical coherence tomography, it demonstrated that if you reduce the LDL further, you are further able to reduce the necrotic cores, increase the fibrous cap thickness, and demonstrate the further resolution of these plaque lesions. Now, if we look at the interheart study, one of the best studies of our time, coming from Salim Yusuf's group, you have seen that in 27,000 subjects in 52 countries, so this is more of a global representation here, that if I look at various risk factors, and he looked at 9 risk factors, 4 standard risk factors, and then he added the stress and BMI on top of it, and then also looked at the alcohol, fruit, vegetables, and the exercise, and looked at all those and clearly demonstrated the relationship between the risk factors and the likelihood of having a heart attack, and demonstrated that if you look at the deciles here of ApoB by ApoA1, so essentially telling you that it is the excess of LDL, that there was 1-to-1 relationship in the odds ratio of having a heart attack. Greater the LDL, greater the likelihood of having a heart attack. And this remains the same, whichever country you go to or whichever continent you are in. Right? The ratio or the odds ratio of having a heart attack remains the same whether you are in Northern Europe, United States, or in the Southeast Asia or in Africa. So wherever you are, essentially the outcomes are same, and then the LDL becomes as important. Now, here you will see that not only that in all the countries and all the continents, even if I go back in time, and these are some of our very intriguing studies, that we started to look at the mummies from various places. Now we have done about 400 plus mummies that we have imaged, and we started to look at the coronary calcium in the mummies. So our first attempt with the Horus team, which was led by Greg Thomas from UC Irvine, and we had started to look at the Egyptian mummies first, and we thought that in those times we lived better, the risk factors were not there, and essentially we should not have had coronary artery disease. So this was probably the best evidence we will be able to produce. But what do we find? Finding the unexpected here. And what was that? That approximately 34% of these mummies from Egypt, and we have now more than 200 Egyptian mummies that we have imaged from various parts in the world, whether they were in Egypt or they are sitting in Italy or they are sitting in Germany, wherever we have gone and we have done them, 34% likelihood of having the coronary artery or other large vessel calcification. Now, calcium, as you know, would remain fossilized even after 4,000 years or 3,500 years. And here you would see that these are the right coronary artery LADs. Most of these arteries, most of these mummies have lost their organs because they were taken out. But wherever they were present, we could see them in the coronary arteries or otherwise in the larger vessels, as you will see the aortoiliac bifurcation here, and there's a significant calcification in this particular area. So now we were like, you know what, these risk factors are just nothing. You know what, you can eat anything, you may not exercise, you live whatever way you want to live. You are supposed to have coronary disease regardless, like we are doomed. Right? That's what we thought. But when we started to talk to Zahi Hawass, who was the antiquity minister and a big scientist, anthropologist, archaeologist, and so we started talking to him. He was the Minister of Antiquity in Hosni Mubarak's regime at that time. And we talked to him and we looked at the demographics, we looked at the way they lived. These were Egyptian elites, right? So they used to, from hunter-gatherers, now they have moved into a civilized society. They eat 3, 4, 5, 6 times a day. They have started to cultivate. They have started animal husbandry. They have access to the goat meat, fowls, beef, everything all the day. And they used to have the festivities in the palace. And what would they like to have? What will be the delicacy? Bird eggs of different sizes that they will consume. What is it that we do today and they did not do at that time? They were all carried in palanquins. They don't drive, but they were carried in palanquins. So we thought that we were talking to a wrong population and we need to look at the risk factors somewhere else. So we ended up in Peru. In Peru, 1,000 years old, hundreds and hundreds of mummies that you will find. People, when the people died, they will put them into the knee-elbow position, put them into the rags and just bury them. And there's so much of salt in the soil that quite a lot of them get preserved. So we had an access to large number of mummies there. But we thought that this was the most effective population for us because these are the people who live in the foothills of Andes mountain. They go up and down the mountain. 50% of them are vegetarians. 50% of them consume alpaca or marine animals, which is like a very lean meat. And so we thought this is the right population. These are all commoners, right? So we thought we have really found the right population. What do we find? 20% of them have the presence of calcification. And this is not a small number, about 150 mummies there also, right? We didn't know what we were looking at. Again, brings us back. And every time that we see this, we feel, you know what, we can eat whatever we want to eat. Like that was always on the back of our mind. It was like, let's debunk this hypothesis of the risk factors. But when we are doing the autopsies in some of them, they allowed us to open the mummies. And what do we find here? That those who had atherosclerosis, there were more women. You don't expect women to have the disease, and these were some of them were the younger women. Why do they have disease? But when we look at their lungs, they were black lungs in them who had the atherosclerosis. So then we started finding the places where these people lived. So they lived in shallow houses, and they cooked inside. It was all the smoke that really, and so we started to realize that there is something more. And this exposure, and the same thing we saw, whether we went to the Anasazi Pueblans in the Utah, Arizona, New Mexico, or southwest of Colorado, or we looked at the Unagan hunter-gatherers in Aleutian Island in Alaska. So something very similar. Why? Because they also lived in subterranean houses or in the cliff holes or in the pit holes where they all would light fire for the warmth. And you will see that there is only one hole that that is there for the smoke to exit, whether it is here or it is in the Alaska. Also the same thing, they are lighting the fire here. You will see that there is just one single hole. So these are all the peoples which are getting exposed to smoke. And similarly in Greenland, in the Inuits, you will see that they will light fire in there. And now that we are starting a campaign next year, and these are the pictures given to me by Annie Griffiths, one of the celebrated photographers from National Geographic, who has visited various countries in the world. She has gone to 100+ countries now and has pictured the kitchens, right? So the indoor pollution, or how the smoke really affects women, and specifically the younger women, how it affects the children who cling on to the women when they are cooking. And this is going to be one of the important features that we are going to go after. Not only that, we also have the images from Otzi, the Iceman, 5,000 years old. He also had atherosclerosis in his carotids as well as in the iliac arteries. And when you look at his stomach content, it was full of, he used to like dry cured meat actually, and there was like a lot of mountain goat that you will find in the stomach contents here. So like now I'll like to bring it to the conclusion here. And so we started to look at some of the population in Bolivia. And these are the hunter-gatherers. We heard that they live very long, 80, 90, 100 years. And if they don't die in the first 5 years of their life, then they are going to live long. And so we went there in Bolivia. This is the river Manuki, a tributary to Amazon. And these are the settlements around the river. So some of the deep jungles and some very near the river. And here you will see that these are the hunter-gatherers. They just walk whole day, gave them the pedometers, the accelerometers, looked at them. They walk about 15 to 17,000 steps a day. They will hunt for monkeys, pigs, and even jaguars, or some piranha from the water that they would, and then they would just simply either grill it, or they would make a stew out of it, and some wild plantains, some papayas and all that they have an access to. And so they live in the open huts, and the stew that they create, and they eat once a day in the night only. So one meal a day, the OMADs. And as you would see there, one of my very favorite couples back in 2007, she's 99 years old and her husband is 85 years old here. Happy families here. And I'm looking at them because they are going for the cataract surgeries here. And if you look at their coronary artery disease, less than 8%, even in their 80s and 90s and 100s, have 100 coronary calcium. This is the heart healthiest population on the planet. So, if your LDL, their LDLs are between 30 to 70. Your LDL is less than 70. Your blood pressure, systolic, is 115. Your sugar is less than 80. Your BMI has never exceeded 24. You live in open huts. You walk all day. There's no coronary calcium. So if you can have it and compare it to all the mesa populations here, they are all here, and here sits the Chimane population. Their genealogic cousins have disease who live outside in these cities. Right? So if they can have it, why can't we have it? If they can eliminate it, why can't we eliminate it? Right? So if you look at all the primary prevention trials, put them all together and extend it backwards, extrapolate it. You want a zero coronary heart disease event. You need to bring your LDL down to 50. You want a secondary prevention, you need to bring it down to 30 if you want a zero. Compare yourself to all the animals in the world. All the animals in the world have less than 100 total cholesterol. One animal very proud of 200 cholesterol is human. Right? Not only that, look at their electrophoretic patterns. All the animals in the world have HDL peak which is higher than LDL peak. Why? Because HDL is about 45 to 50. While LDL in all the animals in the world is 25 to 30. There are two animals in the world who have LDL peak greater than the HDL peak. One is human and the other one is pig. And pig, not because its LDL is high, because its HDL is low, sits on its back the whole day. Right? On the other hand, we bring our LDL up into 130s, 140s, 150s, right? And our HDL remains normal. Still, we have a problem. Not only that, what are we born with? We are born with 25 milligram% of LDL. And in about 3 years' time, this is again a study from Salim Yusuf's group. Sonia Anand presented it, the so-called family study. Now they are collecting the data for 10 years. They looked at the newborns, 25 milligram% LDL, which goes to about 130 to 150. What do we feed to our children in the first 2 years or 3 years of our life? And we have now started to demonstrate our study with Dr. Tom Lucier and Joe Hill. We demonstrated that it is the sugar that is what causes the increase in LDL. And the correlation we demonstrated was that the sugar increases the PCSK9. We are not born to increase the PCSK9. The PCSK9 starts to go up as we start feeding our children sugar. Formula full of corn sugar, corn syrup, corn solids. All our Cocoa Puff, Cinnamon Toast Crunch, Captain Crunch. I don't know what all do we feed to our children that are not only that, the formula do not even have cholesterol. Why? Because they want to make the formula healthy. You add sugar and you make it healthy by reducing the cholesterol. What happens? Your HMG-CoA reductase pathways do not mature. So, results are obvious. You go to European Society of Cardiology, we are a bit timid here in United States, but Europeans are much aggressive as compared to us. They have started to suggest, at least when there is a significantly high risk patients, they have started to suggest that your LDL should be less than 40 milligram%. Right? And the last slide here, which is, I really admire, slide from Dr. Braunwald from his opinion piece in European Heart Journal, what I started with, that can you live to 100 without a heart attack? And he looks at Dr. Horton's model, which was there in the Journal of Lipid Research, which had looked at the presence of PCSK9 in the LDL heterozygous or LDL receptor homozygous people, and demonstrated that you are able to achieve the level which is enough to kill you by coronary artery disease, and that the PCSK9 is able to reach there by about 70 years. And if you have the PCSK9 heterozygous, you will, so this is normal, and here you have some loss of function, you'll be able to achieve this level beyond 100 years of age. So what he's suggesting is that if we look at the normal people here, and if we achieve that level of LDL, and because of that, the atherosclerotic coronary vascular disease threshold by 70 years of life, if at the age of 35, if we start these people on inclisiran, and inclisiran is, you know that it's an antisense against the PCSK9, just 2 shots a year, although he suggests 1 shot a year. So you have flu shot on this side and the PCSK9 shot on the other side. And he suggests that you will be able to live to 100 without having the threshold for the atherosclerotic coronary artery disease. So should be able to live until 100 without having a heart disease. So I'm not going to the prevent. I think we can discuss it. But I would like just to end on a happy note here, like to show you one very decent clip here, that what are we looking at and what should we be looking at. So it is in Italian, but below you have the subtitles.
Scusi, buon uomo.
Excuse me.
Mi sa dire l'ora, per favore?
Do you know what the time it is?
Le 5:35.
10 past 10.
Ma è sicuro?
Are you sure?
È 36, mo.
Like, just like I said.
Grazie. Prego.
Returns back in the evening. He wants to check it out again.
Ha mangiato il ciuchino, eh?
Great day.
No.
Yeah.
Senta,
What is the
mi
time
sapete che
now?
ore sono adesso? Allora.
Again?
Le 7:15.
It's 7:15.
Oh, ma
Damn,
sono
it's
7 e un
exactly
quarto spaccati.
7:15.
Incredibile.
Unbelievable.
Ma lei come fa a leggere l'ora nelle palle?
How do you know the time by touching the
No,
donkey's
ragazzi.
balls?
Sotto c'è il campanile, vedi? Che vedi? 7:15.
So we need to change our thinking. What we are looking at is not right. Stenosis is not the way to go. We need more. Thank you.
Well, fabulous. And I know we've had a ton of people join us online as well. Let's see if there are any questions for Dr. Narula.
Hi, Dr. Narula. Thank you for that presentation. That was amazing. My name is David Maloney, and I was part of some of those shear stress studies with Dr. Samedy with the FAME2 data. Really great to see you present that also. So my question is kind of wondering, what kind of study would you design if you were to try and demonstrate that maybe in a larger population that shear stress it can be used as a predictor for vulnerability in patients? How would you go about maybe demonstrating that?
So the question is, what would be the role of shear stress in this particular population?
I guess if you were to design a study to demonstrate that shear stress, because I think the FAME2 study was a very small cohort, and we need to validate it in a larger population. And I'm just wondering if there was how would you go, what kind of population would you look at, and how would you design that study maybe?
So obviously we'll be looking at the stable coronary population, right? And you remember that 2x2 table that I created? You took the picture of it, right? So, and that was the JACC imaging paper. So that's the central illustration for there. If you replace the high-risk plaque by your shear stress, so shear stress, whatever cutoff point he comes up with, whether it's 471 or cutoff points may vary or whatever else that would be, or maybe we'll have a scale there, whatever it is. So if I put it there and demonstrate that it can literally replace the high-risk plaque. Now, last night I was discussing with Habib that our problem with the high-risk plaque is that the assessment of high-risk plaque is still contentious. I look at it and I tell you that, okay, you know what, it's positively remodeled, it looks very aggressive to me, things like that. There's a pretty subjective thing, and you cannot depend on the people reading it. Right? Automated ways are now demonstrating clearly about the luminal stenosis and all those things, but when you look at the plaque pathology, there's still quite a lot of uncertainty about that. Now, and the problem there is that we compare them to the gold standard, and even in the gold standard, there is an uncertainty. Intravascular ultrasound doesn't give you everything right there as well, right? So why does that happen? You have got different type of machines. You have got different kind of KEVs that you are using, the amount of contrast.
Welcome to Poly Real Connect service.
All those things. So we basically need something which could be more definitive. And the luminal physiology or pathophysiology would really be way more indicative, because here you have a contrast. You are not dependent upon the level of the contrast. What you are looking for shear, which is the mechanical or flow dynamics that you are going to look at. FFR you are able to identify quite well by looking at the flow. Similarly, would I be able to look at the mechanical properties of the plaque without having to look at the vessel wall? So if I replace that with shear stress, I do not know whether I would now need a 2x3 table, or can 2x2 table do it. If 2x2 can do it, I tell you, you have literally conquered the world.
Yeah, I guess you see it more as replacing the high-risk plaque factors and not in addition to them. Or you think there's a room for both? I
would like to see it as a stenosis or FFR plus the shear. If that gives me the answer, even if it muddies the field a little bit more, but it gives me, 2 times greater number of people who require intervention, I'll be happy with that,
Right. Thank you.
as long as I don't miss them.
First of all, I must say it's that amongst the many talks I've heard, obviously, not only have you created the field, but the idea of kind of zooming out and looking at populations over time and understanding some of the sort of non-traditional risk factors is important. So let me ask you about a preventive cardiology question. With respect to coronary risk factors, where do you stand on inflammation? And obviously it's key in terms of the pathophysiology, but can we assess inflammation either using HSCRP or other biomarkers? And then do statins, PCSK9 inhibitors, or even inclisiran really target the inflammatory aspect of atherosclerosis, or do other therapies, such as the ones that Dr. Ridker and others suggest, need to complement our target on Lp(a) and on LDL?
So, I mean, it's a great question. Where does the inflammation stand? And I have some radical views on that. I feel it is all LDL, and LDL is causing it. LDL is sitting in a place where it should not be sitting, right? So it causes inflammation. And if I reduce LDL, and if I take the LDL away from the vessel wall, probably the inflammation should reduce. But that does not happen, as has been shown by Dr. Ridker in multiple of his studies. And HSCRP is one of the simplest way of doing it. It could be even more refined markers. You can use MCSFs and all other things which you can bring in, or interleukins and whatever else is needed. Or now, even as you are seeing in the CT angiograms, we can look at the perivascular fat attenuation and whatnot. So the possibility is that the more you reduce the LDL, the better you would do from inflammation. We did the Jupiter study. There it was 110 was our cutoff point and things like that. And were we really at the level where we should have been? Have we looked at the inflammation in the people when we have brought it down to 25, 30 where we should stand? Probably we'll have very little left after that. But there is a possibility of what we call as, and there was an editorial which I did with Luisa Arbustini in JAMA long back, and it was on all about inflammation, added inflammation, and out of proportion inflammation, right? And the importance was that normally it should go away with the LDL reduction. But sometimes you have other systemic diseases where you have inflammation going on. You have psoriasis, you've got lupus erythematosus, you've got polyarthritis, you've got this, that. All those places, probably you might require an anti-inflammatory drugs, which you are giving for those conditions, right? And the third one could be out of proportion. Sometimes you probably overreact. Probably it's more like an hypersensitivity to the thing. There might be a role. And I think I would go with very simple colchicine in those cases if we really find that after having reduced myself down to 25 LDL, if I still am inflamed, obviously I have to do something. But I think I would first reduce LDL before I start reducing the inflammation.
Got it. Yeah. If there are not any, I have one other question, unless somebody else has a question. Go ahead. Sanjay Lal, non-invasive cardiologist, preventive cardiologist.
Thank you on that very insightful talk. Most of the data that you presented has been associated with CT angiography. Do you see much of a role for nuclear imaging? And do you see CT coronary angiography supplanting nuclear imaging?
You know what, I have often not gotten involved into one being better than the other. What I feel is that we are reaching a stage where we should now be able to assign the roles to various non-invasive tests where they belong. My feeling is that the first assessment for coronaries has to be CT angiography. There is nothing that gives you a better information than CT angiography. number one. You talk about the valves, nothing gives you better than the echoes. You go to the cardiomyopathies, nothing tells you are structural, nothing gives you better than the MR imaging. So I think rather than we talking about this versus that, we should really find the niche areas for that. And that is the reason that when we started the JACC imaging, my first editorial, if you'll read, I really wanted to find as to where should we be going rather than at those times the attempts were, and Dr. Samity would remember, we used to have all these debates, SPECT or PET, PET or CT angiography. I mean, like or stress echo versus stress perfusion and things like that. We used to get into all these debates, and then MRI comes in, everything under one stop and shop and this and that and whatnot. So I think that's a wrong way of a practice. But then as far as the nuclear perfusion is concerned, you will see some of the very decent studies which are coming, and actually Lance Gould will be presenting it at the European Society of Cardiology this year, what is called the Century trial. He has treated people to goal, and he has talked about looking at the subendocardial perfusion versus the epicardial perfusions and things like that, and he demonstrated that they are the best determinants of outcomes and that everybody can be. So yes, we can almost reach the similar level of conclusions by doing a PET imaging as well. Because as I presented to you, that the abnormality starts to happen when you've got a significant positive remodeling and all. It's going to give you almost the similar kind of an information that you'll be getting from CT angiogram. But if you take my hunch here, I started my life as a nuclear cardiology person, and Habib knows it very well because we all work together in that area. But your gatekeeper is definitely going to be CT angiography. Decide whether you need anything or not, whether you need medical therapy. You need to be sending this patient for coronary intervention or even surgery. You don't even require the invasive coronary angiogram. You must have read our fast track cabbage paper, which just got published at the American College of Cardiology meeting. And Patrick Srois was the principal investigator, that we did the coronary bypass surgery after doing a CT angiogram, no need for invasive coronary angiogram, right? And out of 120 cases, there was only once that a surgeon was not satisfied by the CT angiographic findings or the CT angiographic guidance of carrying out and we have done complex coronary bypass surgeries with railroads. You can't even imagine how complex they are, all based on CT angiograms. So in my opinion, I think the CT angiogram is here to stay when it comes to the coronary artery disease, and you don't require anything else.
Can we get Dr. Gersh? I was gonna call on you if you weren't gonna ask a question. So Karen Gersh is one of our cardiac surgeons. Also does a lot of robotic cardiac surgery and lung surgery.
There, that's better. So I apologize, I was a little bit late at the beginning for a conflicting meeting, but on that subject, Dr. Samity and I have talked. I do robotic assisted surgery, and I avoid sternotomies and go through small incisions, and patients go home post-op day 2, post-op day 3 with no limitations, beating heart, revascularization through just a small 8 millimeter ports. And I see the utility of this for us to target a single vessel, which is the most paramount in revascularization. That when we look at revascularization as a surgeon, we've always been taught fix everything, but do we really need to do a sternotomy and fix everything? Does that really foretell a better outcome for my 84-year-old lady? Or can we target a specific vessel for the optimal subendothelial type of revascularization that I need to provide for this frail person who has a very high Syntex score and probably is not best served with PCI, but likewise a sternotomy, breaking that bone, putting her on cardiopulmonary bypass is probably not the right thing either. So can we tailor our surgery in the future to target the most important vessel? And we kind of do that here now, where we target an LAD and then we come back a few months later and PCI something else. and we've had very good results. So in the future, do you see a shift in how us surgeons are going to address our aging population who are frail with complex disease?
Very contentious question, to be very honest with you. And I have had multiple discussions on this with John Puskas. John Puskas and I used to share a suite where we used to sit, and we have spent 7 years together when he was at Mount Sinai. And he recently came back to Atlanta, as you know, this month. But we have always talked about it. And this fast track cabbage also we did together when we did the CT angiogram. And I think it has become even more important a question after the robotics have started. Like, you are not opening up the chest. Previously it was that if you are opening up the chest, try and fix every possible thing that you really need to, because you are not going to be coming back. Right? So you should try and do the thing. I think CT angiography gives you a lot of insight here in terms of what are those plaques which are likely to respond to the medical therapy and which are not likely to respond to medical therapy. I mean, like, this is something which we never had that kind of a facility with us in past. Currently also, I think the coronary bypass surgery should be attempted only after we have completely treated our patients, unless it is acutely needed or whatever else it is, unless we have completely treated our patients and they are on the optimal medical therapy, and try to see what exactly has happened to their plaques. I mean, are we able to squeeze these plaques? How do we do about it? And then with the robotics, sure, going for the LAD, for example, if this is the lesion which is definitely not going to respond to the medical therapy and the patient's symptoms are not going to be amenable to the medical therapy, or it's a patient who is high performing patient. I mean, like, he goes mountaineering, he's somebody who exercises a lot. I think I would go for a robotic LAD Lima and probably would do much better than anything else in this particular case. And you can do it with a similar kind of a post-op care. I mean, it's a procedure which is much safer, much easier as compared to. So I think the decisions now probably would be eventually when we are mature enough in looking at these plaques. With the CT angiography, I think we will know a lot better. And you yourself have seen all these syntax studies and all, specifically from Patrick, where he has demonstrated that the people who had outcomes, they were predominantly dependent upon the optimal medical therapy after the surgery rather than based on anything else. So it is all about taking care of the plaques. If I can reduce the amount of the fatty depositions, if I can take care of the necrotic cores, I think the need for surgery would become very much more specific than what we talk of. And then the role would be much better for a surgeon in terms of doing the robotics rather than opening the chest. Now, it completely changes when we come for the viability studies and things like that. It completely changes its expectations and the way we look at it. But I think most important thing here is the optimal medical therapy before we attempt to do anything else.
So maybe we shift the paradigm where we have a patient who has stable angina, waxing and waning, that we don't shift them off to surgery immediately, that we do try goal-directed therapy. But what would be the time frame of failure for the goal-directed therapy prior to coming to a surgeon? Because right now, as it's been historically for the last 40 years, they go to surgery. They get shifted to a surgeon. So do we need to kind of pump the brakes and optimize these people? And then what does that look like? What is success versus what is failure? Because for robotics, I mean, I could put an IMA to the right, an IMA to the circ, not just an IMA to the LAD with very low risk. So I can target a vessel versus globally having to revascularize everything through a sternotomy approach. And overwhelmingly, these patients do better. So what would be the paradigm shift? Like, when do we say success, failure? When do we tell our cardiology colleagues, hey, you know what? We need to try goal-directed therapy for X number of months, do another CT scan. So what's the threshold for us to take them to surgery?
I mean, I don't think that I'll be able to give that answer as to what would be the threshold here. But the fact remains that The reason that we did better with these surgeries in these cases were essentially because it was able to cover up for various more plaques that would eventually rupture, right? And that is the reason that you did much better in terms of survival in those cases, which, if I'm giving the optimal medical therapy, may not remain as relevant now, right? So the entire thing, I think, would require a much more aggressive heart team approach rather than so we sit down together as an imager, as an interventionist, and as a surgeon, and then decide where exactly we are going, and can we provide an LED result which is going to be like way more lasting as compared to what the intervention would do. So I think would require a lot more investigation here, but definitely optimal medical therapy first and a heart team approach where all three of us are sitting together. I know it's not a satisfactory answer, but that's what I would.